Good evening, everybody. My name is Lynn Wilson, and I'm head of the Department of Family Community Medicine here at the University of Toronto. I'm so delighted to see so many of my colleagues, both from family medicine and from public health and others. You know, it's funny, Paul, I've been muttering to various people this week that I was a bit intimidated to be following you, because you have a real reputation for your speaking, and certainly your writing is really spectacular, but I had it wrong. I should have been intimidated by following Sarita Verma, Catherine Merlot, Paul Farmer, and Howard Hu. You've all spoken so beautifully. As I was preparing for today, and this has been a really wonderful event for us, for our department, and for our students, I was really touched by something I read simply on the Partners in Health website. It was an excerpt from one of your books where you really made some pretty strong statements around daring to imagine, daring to think big, and creating very powerful partnerships. And for me, it brought it home when you showed your two slides, the one with that devastating rubble and talking about the loss of all those nurses, and then the very beautiful picture of your university hospital. And I think that that just says everything about if you really truly dare to dream big, and if you work with all the right people and you're just relentless, it's quite remarkable what you can accomplish. And I consider that to be very inspiring and something that I will be thinking about a lot as I work with all my colleagues in family medicine and beyond. So what I wanted to do is just to talk a little bit about primary care and family medicine and health equity. And I'm going to just give you a couple of examples of some of the work that we've been doing in family medicine. And you know, I'm proud of the work that we're doing, but I think that we've still got a long ways to go. And I'm going to talk about what I see as some of our challenges and ways in which we need to challenge ourselves. So Paul's already made some very important points about the, I'd have to say, the overwhelming volume of evidence now, research evidence showing that countries with strong primary health care and strong primary care clinical systems have better health outcomes at lower costs. And this is a real range of health outcomes, including lower infant mortality, lower all-cause mortality, lower cardiovascular mortality, and improved screening for a variety of cancers. And in fact, lower suicide rates. So it's quite remarkable, and it's whether the studies have been done in lower middle-income countries, but also in high-income countries. And so knowing that, it's really helped us as an academic department of family medicine feel quite convinced that one of our roles as we consider our social responsibility as an academic department is to help work with others in improving primary care capacity in their settings. And so I'm going to talk to you about two projects that our department has been engaged in. One is a local project, and it's not one that's under the direction of our department, but quite a number of our family medicine faculty are engaged in it, and I think it's a remarkable example of dealing with health inequity right in our neighborhoods, right at home. And then the second example is a global health example from Ethiopia. So let's start with our local example, and this is around the participation of 30 family physicians, the majority of which are academic family physicians here at the University of Toronto, who are working with the Inner City Health Associates. And how many people here, are there any people here who work with Inner City Health Associates? And look at you all, isn't that fantastic? And there's some family docs and some psychiatrists. And the vast majority of those individuals are from St. Michael's Hospital, which is one of our major teaching hospitals here in Toronto, quite remarkable hospital in my opinion, in everybody's opinion. So I want to tell you a little bit about Inner City Health Associates. So I can't claim it as a departmental initiative, but there's so many members of our department, so many of our students who work in it. And I think it's a remarkable example. So there are 70 physicians who work in the Inner City Health Associates, and they work with individuals who are homeless here in our city of Toronto, and they provide health care and health-related programming in the community. Homelessness, I'm sad to say, is a significant problem in Toronto. There are about 28,000 individuals who use shelters each year, and about a third of them have a serious mental illness. The vast majority have no regular source of medical care. And in one study that was done of these individuals, about 27% said that they felt that they would have a better chance of being able to achieve stable housing should their health issues be dealt with. So the 70 physicians of the Inner City Health Associates include 35 psychiatrists, 30 family doctors, 2 community medicine specialists, 2 internists, and a pediatrician. And the majority of them are affiliated with the University of Toronto, and as I said, St. Michael's Hospital. And they work in inner city health associate clinics in over 40 frontline homeless agencies across our city of Toronto. And the main operations for this group include clinical care, population level care, and medical education. And so that goes back to both of your points around the fact that academic physicians can actually make a remarkable difference in communities, including very, very traditionally underserved communities. And in fact, one would argue that we have a responsibility to do that, given the resources that we are so fortunate to have. And the other very important thing that relates back to the message of Partners in Health and Paul is that the model places a great emphasis on collaboration. And in speaking with my colleagues, this has been a lot of hard work over a lot of years. Is that not true? Like really trying to build very meaningful relationships, whether they be with the City of Toronto, with the Toronto Drop-In Network, Toronto Community Care Access Centres, St. Mike's, the Centre for Research on Inner City Health, and the University of Toronto. And so through collaboration, that's facilitated access not just to primary care, but also tertiary level care that occurs right in the shelters or the other agencies, and improved ability to access support for finding housing, improving food security, et cetera, et cetera. So it's a really, really fantastic example of what you can do if you really believe that you can create something that's very big in a situation that seems kind of impossible, and also that you work with a broad range of partners in a really, I'm going to say, a truly sort of equitable, flattened type of organization, instead of the hierarchies that often, I have to say, physicians can seem to gravitate towards. So I think that this is a fantastic local example, and I wanted to talk about it because sometimes some of our students and some of our faculty say, well, I don't think I can ever go to Ethiopia for whatever reason, but what can I do at home? We need to do more than what the Inner City Health Associates are doing. We have a big issue around lack of access to high quality care for example, Aboriginal individuals in the city of Toronto. And so that's the sort of thing where thinking big and powerful partnerships can make a difference. So the second project I'd like to tell you about is called the Toronto Addis Ababa Academic Collaboration. And before I even talk about it, I feel like I should have you, Claire Payne, up here at the, and Dawit, up here on the stage talking about it. But I'd like you both to stand up, if you don't mind, just for a sec. Claire is one of our faculty from the Department of Psychiatry at the University of Toronto, and the absolute, well, I think of you as the mom of TAC, if you don't mind. And Dawit is the head of the director of postgraduate education at Addis Ababa University in Ethiopia, and a critical partner for us as we've worked to with our Ethiopian partners in establishing the discipline of family medicine in that country. So I'll just tell you a little bit about it. So TAC, this academic collaboration, is a partnership between the University of Toronto and Addis Ababa University, which is one of the major universities and medical schools in the country of Ethiopia. And Claire, we're up to 16 different departments of the University of Toronto, including ones well beyond medicine, such as engineering, pharmacology, and right, et cetera, et cetera. Yeah, so this is a very exciting initiative. And I think one of the important things I've learned about working with TAC is how powerful it is when you get an entire big giant university like ours, and you have different groups, it's transdisciplinary, all learning from each other and all building on each other's successes and kind of motivating each other. And when you've got very, very thoughtful and effective partners and a chance to really establish a durable relationship. So this initiative, TAC itself started way back in 2003 when some of our colleagues from the Department of Psychiatry at the University of Toronto started working in Ethiopia with Ethiopian psychiatrists around developing a residency program, and it's grown immeasurably from there. So it's another example of a think big. So our Department of Family and Community Medicine heard about what psychiatry and internal medicine and others were doing, and in fact, I can't remember who it is I called. It might have been you, Sarita, but I remember seeing an email that I think somebody copied to me by mistake, talking about all the stuff going on in Ethiopia, and I saw all these names, and it was all these fantastic specialists, and I got on the phone like, because I said, oh my God, Ethiopia, primary care, where are we? And we're coming, you know, right? We're not necessarily invited, but we're just going to show up for this one. We're crashing the party. And I'm really glad that we got involved. So a lot of work went into establishing Ethiopia's first family medicine residency at AAU, and our first students started their residency almost a year and a half ago now, in February of 2013. But there was a tremendous amount of work that led up to it, because we were acutely aware of a couple of things. First of all, the Ministry of Health in Ethiopia had been working for a couple of decades at trying to strengthen and grow primary care. And we were the last people to think that just producing a bunch of family doctors was what was going to work for Ethiopia. So we learned a lot about what was going on in terms of community extension workers, clinical officers, the community health centers that you had in rural areas, and the long history of general practitioners who were working throughout your country. We also learned, though, that the general practitioners were finding it to be a great challenge. They were leaving medical school and heading out into rural areas and really practicing under a fair bit of duress, right? You know, just dealing with every possible situation you can imagine, including some of the ones that you described, Paul, in terms of infectious diseases, trauma, being the one to have to go and conduct surgery. And, you know, we heard some pretty gripping stories about their circumstances. And what we heard from our colleagues was that the opportunity to train more specialized generalists would likely help to make a difference. In other words, to have some family physicians who could work with this array of primary care providers and provide some support and some expertise, and maybe make it easier for generalist physicians to continue to work in the rural areas, not feel that they needed to come back into the big city, retrain as a specialist, or perhaps leave Ethiopia altogether. If I got that right, that was kind of what we talked about together. So we had a very cool study that we did where we did a time motion study of GPs in Ethiopia and interviewed them to sort out what a curriculum might look like. We did a lot of faculty development, continuing education with Ethiopian physicians, and then ultimately with our Ethiopian partners, and importantly, some individuals from the University of Wisconsin who came with MEPI funding, which we were pretty happy about. We developed a competency-based curriculum. There's two things about this program that I'm excited about. Well, there's many things, but there's two new recent things that I'm excited about. One is that there's a real emphasis on quality improvement, which is pretty new to Canadian family medicine, and it's going on in Ethiopia. And I think even more importantly, the recent discussions around integrating the family medicine residency with public health. So right now, the family medicine trainees do 3 years, but they do have a public health portion that goes throughout the residency. And now the conversation is around about adding a 4th optional year in public health, because more and more medical schools are being built, more and more students are going out, and we really are going to need expertise in public health to think about how we deal with health systems and look at things at a population level. I say all of this with a little bit of caution because I feel like I'm talking about somebody else's healthcare system and country. So, but this is what I feel that I'm learning as I see these wonderful messages coming back from Ethiopia, from our faculty. So I wanted to tell you these stories because I think that you can, health inequities occur at home as well as far away. I do think it's important to think big, and I think one of the things I'm grateful for from leaders like Sarita and our Dean of Medicine and Claire and others has been, you know, instead of doing small things in a lot of places, how about really trying to do something special in a couple of places, and then as time goes on, think, okay, who else can we work with, or the people that we've worked with, for example, our Ethiopian partners, who else can they teach, and kind of more approach it that way. And again, partnerships are everything, and that I've been learning from you, Catherine. You really are becoming a scholar around partnerships. Catherine's done some very important work thinking about what it really means to be an equitable and respectful partner. So at this point, as I've listened to you today, Paul, and read some of your articles and portion of your book, I realized that our department, although I think we're off to a good start, we could create even more powerful partnerships and think even bigger. I can really see that that's possible. And so you've done us a favor by providing us with your examples, because I think it's very inspiring for us. And given the size, you know, we've got more than 1,400 faculty in this department of ours. We should be capable of doing far more. And so thank you. Thank you very much.